Hello, everyone. I wanted today to discuss our agitated delirium protocol as well as droperidol, and this will be in sync with our training for the month. So let's first start with the agitated delirium protocol. So if you can see that we now have it divided up into mild, moderate, and then we have severe. And obviously we have P1, P2, with P2 being the severe. And the reason why we did that is because sometimes we'll have patients that are mildly agitated. Sometimes we're going to have some that are kind of on that cusp. And then in the severe agitations, the life-threatening, the hyperactive delirium. And that's, where you're really having to treat them. So when it comes to this, we try to do the best we can. If they're mild or moderately agitated, see if you can get a 12 lead. And the reason why you're going to see with drugs like droperidol is it actually elongates your QTC. So if you can do that, that's great. I understand that you will not be able to do that in hyperactive delirium. But with mild agitation psychosis, couple options you have. You can do Versed IM 5 milligrams. You can also do IV or IO. And then you also have the option of using droperidol IM 5 milligrams or IV IO. When it comes to moderate, you can actually do the 5 milligrams of Versed and the droperidol IM 5 milligrams as well. Obviously, if you have someone elderly, you want to decrease that dose because they're actually going to be a little more sensitive to it. And then when it comes to actual hyperactive delirium, which used to be called excited delirium, your options are a little different. Ideally, we start off with Versed, 10 milligrams IV, IO, IM. Most likely this will be IM. And then you may repeat this one time. Now remember, if PD has them prone, you want them all to be supine. Having a patient like this prone inhibits their respiratory status and they can code pretty quickly. The other thing to look out for in these patients is when you have someone who's really hyperactive delirium and then all of a sudden they get quiet, that is a huge red flag as things are going south. So just be aware of that. Now, if you've given the Versed twice and they're still out of control, that is when you can go to the ketamine IM, and that's 4 mg per kg. And please remember, it's ideal body weight, not total body weight, okay? Ideal body weight is based on height. There are tons of apps out there that can calculate this for you. MD Calc is one of them, and it has that calculation within it, and it's free, so consider doing that. We also have bicarb in there for concerns for acidosis if that were to occur. So that is essentially your hyperactive delirium protocol. When it comes to droperidol, our indications for droperidol are really agitated or what we used to call excited delirium. We can also use it for migraines, but that's something you're going to have to call me about because there are some other options that we can do. Contraindications to it are Parkinson's will actually exacerbate symptoms, and then obviously prolonged QTC. If you have a QTC greater than 500, you don't want to do it. There used to be a black box warning with droperidol, so be advised of that, but that was because of QTC. But what they found that it was it was based on a couple case reports. So it wasn't great evidence, but it is what it is. Many people are using droperidol these days without any issues. Just know when you start mixing it with other QT prolongators like Zofran, you can have a really exacerbated QTC. So just be aware of that. It's basically what they call a butyrophenone antipsychotic and a dopamine antagonist. That's really what it does. So it antagonizes the dopamine receptors, and then it also interferes with the GABA, and that's how it does its action. It works in about 3 to 10 minutes with peak effect at about 30. The duration's of about a couple hours to 4 hours. Now you can have that akaesthesia that they can't stand still. They feel like they're shaking, or dystonia, and be advised if you start having akaesthesia or dystonia, you can try some Benadryl. Other things it can cause is hypotension and obviously the prolonged QT. So again, the dystonic reactions, what do we do with that? We do our usual, we treat with Benadryl to resolve it. And then obviously that's really about it. Now our dosing, first of all, we don't give it to anybody under the age of 16. That is an absolute no-no unless you contact me and there's a really good reason for it. We have plenty of other options we can do before then. For agitated or excited delirium, obviously we just went over the protocol, and then you can repeat the dose ×1, and then I do have a migraine dose built in there just so you have a reference to it in case we need to do it. As always, if you have any questions, feel free to reach out. Thanks, guys.